Greetings, everyone. Welcome to Monday, September 19th. Thank you all for coming here and being to our first presentation. Just a little administrative stuff. If you're interested in presenting your research next semester or next fall or the next 5 years, please, there's a pad back there. Please feel free to write your name down. We'll give you a call, see what you got, and we should have our schedule for the spring, hopefully in a couple weeks. There's just been some challenges with reserving rooms for the spring semester since we don't have a mechanism to do that presently. Also, 2 weeks, Dr. Brian Krim, October 3rd, will be here to present his research for the Department of History, and we'll see Dr. Krim in 2 weeks. Thank you. Today's speaker, Dr. Jenny Hall, has been at the University of Lynchburg since 2015 in the health promotion and public health programs. Dr. Hall earned her EDD in Community Health Education from the University of Northern Iowa and is a Master's Certified Health Education Specialist. And today, Dr. Hall will present her work on ticks, tick-borne diseases, and provide data on surveillance, some information on prevention and patient advocacy. So please give it up for Dr. Hall. Thank you.
Awesome. Thank you all so much for coming today. I'm going to get right at it because I'm going to be speaking about 4 different sort of research study areas that I've been working on. Just to give you a little bit of background, and I'm sure you're well aware of it just by looking in the news, the burden of tick-borne diseases has been increasing, and tick-borne diseases, or TBDs, have been expanding geographically. It's been a human health threat for over a century now, and is an emerging global public health threat as well, hence my interest as in the public health field. Estimates now are getting closer to 500,000 Americans diagnosed and treated for Lyme disease annually. And the prevalence of post-treatment Lyme disease, or what you might hear of as chronic Lyme, was estimated to be near 2 million Americans in 2020. In the U.S., we're looking at tripled cases from 2004 to 2017. So again, showing that expansion. Global warming, climate change is part of it, but there are also other reasons as well that I'll get into. There's actually at least 20 known conditions caused by 18 different tick-borne infectious pathogens that can result from a tick bite. Often ticks carry multiple at once, so it's really important to know that. It's not just Lyme. We often hear just about the Lyme. And in the United States, they make up 75% of all vector-borne diseases each year. And they are increasingly recognized as a neglected subset of emerging infections. So where are they? As you can see here, Virginia is the hot spot on the right. I'm going to focus more on our area of the world, but the American dog tick down here and the brown dog tick, these have the Rocky Mountain spotted fever, which we do have quite a bit here in Virginia as well. The black-legged tick is where you'll get Lyme, where you'll see Lyme disease, but anaplasmosis, auriculosis, babesiosis, and Powassan as well. And then here, the Lone Star tick, the one that you may see, the nice little white star, they call it, on the female tick, that's where we're seeing alpha-gal. But it also has Heartland virus, tularemia, auriculosis. And for those of you, I'm sure in this area you've heard of alpha-gal, or other people will call it the red meat allergy, which drives me crazy because you will see it's way more than red meat. It goes way beyond that. Oops, mine's a little backwards here. When we talk about alpha-gal, it is not reportable to the CDC. Some local health departments are starting to do some surveillance around it or reporting. But this is a website that is kind of the go-to if you know of anybody that has it. This is evidence-based and really stays up. But anybody that has visited the site can put a pin on it where they've got it. So you can see it's every continent but Antarctica and Arctica. And it's likely to be largely undiagnosed in many of the developing countries in particular. So the black-legged tick, which is, again, the source of Lyme disease, this is an example of a map on surveillance and when you establish a county. So the red counties have been established, so it means there's 6 or more of a single life stage, or even more than one life stage of the tick collected within that county over 12 months. The white counties does not mean that there aren't any ticks there. It just hasn't maybe had any surveillance activity going on there reported. So you'll also see, if you look at United States and the surveillance, it kind of drops off more on the West Coast as well. So surveillance across the United States is insufficient. There's no national surveillance program, and a lot of public health departments just don't have the resources for it. So that's what got me started in it. My environmental health students were wanting more activities in class, and so I was like, all right, we're going to start tick driving. We're going to start doing some active tick surveillance. So I'm going to credit Rebecca McClellan back here in the Health Promotion Public Health Department, because we were the first ones. We worked with Kyle Mullen from the Virginia Department of Health in Lynchburg and an MPH grad, and we started heading out. Peaksview, I think, was our first little spot. So this is literally a dragger, and you go along, and there, I'll tell you our methods a little bit more, but you literally just we go along the trails and drag and stop. I'm not going to go into all the details, but you can see there's not. But I think it's like fishing. You see who can catch the most, the biggest, and the different types and all of that stuff. So it's fun. So I just wanted to credit. I've involved a lot of people in dragging over the years, and so wanted to credit them here. And I'll get into it. Biology and environmental sciences are really starting to get it into their lab, but working with the ERA network, what I'll mention at the end here. So this is what we have focused on. A lot of the literature and the county level data is focused on transects in large areas of land to look at prevalence over time. I was concerned with it reaching people, and so looking at trails and parks where people sit in park benches. This is the university's trail system, and I knew I was going to forget the new labyrinth walk. So we looked around there. So really where people would come into contact with those. So these are some of our students and dragging here. And we've done I'm going to count Judy Muir here as one of the, who has done a lot of dragging as well. And these are her maps down here, and I'm crediting Dave Peralt for helping us integrate mapping into our projects. So we've done Blackwater Creek Trail, we've done Percival's Island, Peaksview Park, the University Trail Systems, and then practice sport fields where like balls would go off in and would reach people. I've got a student in Buckingham County doing that as well right now. And then Judy also led off, during her MPH here, she led off the identification project and has become the master guru in that. We got a Schul fund and provided some ticks over to biology to do a tick identification lab. And we use the Virginia Department of Health's, these are the main ticks you're going to find in Virginia. The Asian longhorn is not known yet to cause human disease. However, they have been finding now that it has the potential to, and of multiple ones. So that's scary because it is super invasive. It didn't hit the Western Hemisphere since until 2017, and it's now in 17 states as of last year. So when we were doing our surveillance activities, we also looked at what Virginia Department of Health had in terms of the main types of ticks and the stage that they were and known during the time of the year. And we hit almost every month throughout over a year, and it's pretty in line with that. The Asian longhorn has been expanding. You can't say we've looked at necessarily the stages close enough to counter that, but we're not seeing a lot of differences from this. And this was from 2019. So what I'm really super proud of is that because I was excited to find so many ticks out on the trails and park benches and things, but I made a call over to Parks and Rec, and that relationship happened really quick. They were on board and worked with Graduate Studies and UCM and Parks and Rec to develop tick prevention, education, and warning signs that are across the trails and park systems here in the area. So I'd like to see them. There's a new law that they need to be across the state and the trails. So I don't know how to get them more. Would like to see them across the state. I don't know if they'll be this same one, but work with others. So that's sort of the surveillance project. I'm now going to move into some of the patient experience studies that I've been working on. So this was just presented last the week before last in Amsterdam at the Tropical Institute in Amsterdam at the 16th International Lyme and Tick-borne Disease Conference. And so I'm going to quickly go through the 3 posters and research that I presented there, and we'll just do that later. So in 2021, you may have received an email from me as well. I did a mixed method tick-borne disease experience survey. I used the Horowitz Multiple Systemic Infectious Disease Syndrome questionnaire which is validated for Lyme disease for symptoms, and then a lot of open-ended questions around work, quality of life, experiences with diagnosis, management, and treatment, and then also recommendations for providers and patients. I also did semi-structured 30-minute follow-up interviews, and all this was done through snowball sampling, through email and social media. So I did some social media sites of tick-borne disease support groups. And primarily was descriptive with content and thematic analysis that I originally did by hand and then followed up with qualitative analysis software, both in vivo and Quarkos. So there were 434 that participated in the survey and 43 in the interviews. They were bitten or exposed, not where they live, but they were bitten or exposed in 7 countries and 34 states, as well as Washington, D.C. So a student did this map as part of her project. And then I put this together just the other day, but you can see where the participants were. So pretty close in line with where a lot of the tick-borne diseases that we see in the United States. They were diagnosed with at least one of 18 different tick-borne diseases. Most were Lyme or alpha-gal, but then 1 in 3 reported having at least one co-infection, and 3 out of 5 were misdiagnosed at least once. Misdiagnosis is pretty common, and the most common misdiagnosis for all of them together of the 18 were fibromyalgia, chronic fatigue syndrome, some psychological condition, depression, anxiety, or rheumatoid arthritis. For alpha-gal syndrome, the top 2 were chronic fatigue syndrome and irritable bowel syndrome, and then some of these here as well. Health insurance covered all costs for about 1 in 5, and at least some costs for half. And then out-of-pocket costs for treatment ranged from 0 to an estimated high of $800,000 over many years. I include this here. It's going to make a little more sense too when I get into my workplace tick-borne disease prevention efforts. When we look at the most common symptoms, you're going to see that they really align with a lot of common other illnesses, diseases, and conditions, so it's really easy to misdiagnose. If that physician's not thinking of that first, or when they should be, depending on the region, it's going to be easily misdiagnosed. So altogether, all of them on the left are combined, so fatigue and tiredness were top on almost all. Upset stomach and nausea, joint pain and swelling, disturbed sleep, and headaches. When I pulled out just for the Lyme disease or Rocky Mountain spotted fever, they were the same. So I did Rocky Mountain spotted fever alone with no co-infection and Lyme with no co-infection, and they had the same top 5 in the same order. So you can see them here, pretty similar to all. And then alpha-gal has the change in bowel movements, fatigue and tiredness, upset stomach, and then the hives or rash is something that's different for that, similar with the allergic reaction. So when we get into work, the symptoms that people had, it affected and interfered with their ability to work for 3 and 5 participants. And through their qualitative responses, it showed that it really affected their ability to go to work, to be fully present while at work, and then to be able to perform their job at their highest potential. So I was inspired in 2020 reading a NIOSH science blog, National Institute of Occupational Safety and Health, by this quote: that it is no longer effective to think of occupational safety and health issues separately than the larger sphere of public health. And I've done a lot of work in occupational health in the past, and so it was just started making sense to integrate this into workplace tick-borne disease prevention. When I started looking out there, there wasn't much out there. People aren't doing it in the workplace. And in the tick-borne disease working group, so in 2016, Health and Human Services mandated a new tick-borne disease working group, and they have reports to Congress. The next one's coming out. I've been hanging out in their virtual meetings. And They identified the workplace as a priority setting, particularly for vulnerable workers and those in endemic regions. And it's concerning there's no known OSHA, Occupational Safety and Health Administration standards. The only known state that has them is Connecticut. And so lots of studies, I don't like the word lots, but there's numerous studies that really show that tick-borne disease prevention programs can work, particularly those that apply to health belief model. And some constructs of that are that really increasing knowledge, understanding about the severity, and feeling that you're at risk for it, as well as having confidence in your ability to actually take part in the behaviors, which the biggest one for tick-borne disease prevention is tick checks. You gotta check. So I know this is a lot on one slide, but this was what I sort of created as part of a business case. I'm presenting at the 3rd International Symposium to Advance Total Worker Health in a few weeks. And so I pulled out, so for absenteeism, by far it affected people's ability to actually go to work or miss work, right? And it was for appointments, for taking time off, related to their symptoms. Some had to move to part-time because of their symptoms. From the post-anaphylactic reactions from alpha-gal, a lot of people wrote that it was 24 hours after that it took them to sort of get back to themselves and make it. ER visits, and then some people have had to go to FMLA, short-term and even long-term disability because of the disease. Presenteeism, the ability to actually be fully present while you're working, thinking about something else or feeling bad so you're not able to focus. So no energy, brain fog, days that they felt their speech wasn't affected, or just this person almost every day just don't feel well. And then productivity, people having to reschedule their jobs or decrease their workload, or just unable to physically do their job. So some examples there. So in some cases, unfortunately, employees were fired, forced to quit or retire early. So because of being sick, because of poor performance, awful flare-ups, and for alpha-gal not being in a work environment that had bathrooms nearby, because there's a lot of gastrointestinal symptoms with that. So, and I'll get to the sort of spectrum of symptoms and how people react to alpha-gal here in a little bit. But people are also triggered at work. So nurses that could no longer take or remove food from patient rooms from reactions, products from hairdressers not being able to cook or be around beef or pork for a chef, and a person having to quit because of limited emergency health care and high cross-contamination. So when we come to the actual exposure, of those that knew they were exposed, so only 272 out of the 434 knew where they had been exposed. Half were exposed in their yard, and followed by a park or while recreating. There is higher risk for people in outdoor professions, primarily agricultural and forestry. But the fact that in this study, and it's supported by other studies as well, that people are contracting in their yard. So Total Worker Health, I'm the one that's sent Total Worker Health surveys around before, is an integrated approach to worker health, safety, and well-being. It prioritizes safety, but then it works to advance well-being. And the other key component of Total Worker Health that aligns, I think, with creating an evidence-based workplace prevention program is that it recognizes both occupational and non-occupational exposures can lead to worker injury and illness. So, protecting workers on and off the job, because in the end, it's going to affect their ability to do their job. So I create from the hierarchy of controls apply to Total Worker Health. Traditional occupational safety and health programs use the hierarchy controls. They've applied it to advance worker health and well-being. I've then now applied it to tick-borne disease prevention. So it's an order from the top is what is considered to be most effective. Generally, you want to completely eliminate the hazard, so you want to get rid of those ticks, but it's pretty near impossible to get rid of the ticks. I won't go into a tangent because of ways that potentially, but so the recommendation here is to implement integrated tick management strategies. You could do some different things with the land, leaf cover, chemical spraying, and those types of things, but also integrated with education and behavioral change strategies. But then also provide supports for employees with alpha-gal so that they're not triggered at work. Substituting is to offer the prevention programs and different supports for people that do have tick-borne disease. And implement total worker health strategies to reduce worker fatigue. There's a lot of evidence-based strategies to reduce worker fatigue, and that was one of the top symptoms that all people were reporting. So to integrate that as well. Redesign for more flexible work schedules, if possible give paid sick days if they are already getting them. Educate, provide education resources to increase knowledge about tick-borne diseases, and then encourage personal protective equipment, personal protective behaviors, and testing. You got to help people know when they may have signs or symptoms and know when to go get tested. And these two at the bottom, the educate or encourage, really go in and align with the health belief model. I don't expect you to be able to read all of this, it's a lot in there, but what I've done is applied the health belief model to the educational aspect with the main constructs for both using personal protective equipment and personal protective behaviors, and then for actually getting screened or tested. So again, people need to believe that they can get bit by a tick and get a tick-borne disease. They need to believe the consequences are bad enough and significant enough to try to avoid them. They need to believe that recommended actions would protect them from the TBD, identify barriers, get reminder cues to actually do the checks, and have maybe tweezers on, if it's a workplace that people are going out, provide them with tools. And also receive a training and resources so they can do that. So that was sort of the one side, and I won't go into that. So conclusions from this study, and where I'm at with it right now, is that the symptoms from a tick-borne disease significantly can impact an employee's ability to work, thus impacting negatively the employer's bottom line. So through decreased productivity, increased absenteeism, presenteeism, and healthcare costs. So particularly in tick endemic areas, occupational safety and health organizations and employers really need to consider implementing a tick-borne disease prevention program, as well as supports for people that may have a tick-borne disease. And then I believe a total worker health approach that applies this health belief model can be an evidence-based strategy that has the potential to not only help protect the worker, but also their families and entire communities, which also aligns with that total worker health approach. All right, we're halfway there. We got two more kind of studies, different things going on here. We're going patient advocacy now. This is from the same study with those open-ended questions coded in the same way. But there is a well-established need to improve healthcare provider education. It is well known that providers just do not know enough about tick-borne disease, and it's really hard to keep up with it. They're changing, they're expanding, they're moving to different geographic areas, so it's difficult, and it's not in the curriculum sufficiently. It may be introduced, but it's not really in a lot of curriculum. And patients increasingly document that it's really hard to find a provider that's knowledgeable about tick-borne diseases and that can effectively recognize, diagnose, manage, and treat their symptoms. And going along with this, the research shows that misdiagnosis, which we've talked a little bit about, undertreatment or overtreatment, increased healthcare costs, and decreased health-related quality of life all can result from this lack of provider knowledge. So I did ask for recommendations on how to improve care, but I also had questions just about open-ended comments about their diagnosis, management, and treatment. So I used responses from these. And this was the word frequency from just the question on recommendations for providers. And so you can see listen, believe, which are going to come across in please, treatment, educate, know. You're going to see this kind of align with the recommendations that come out of this. I went back because alpha-gal got into two, and I tried to kind of connect it and do it multiple times, and it kept separating them, even when anyway. So, but it's there. So many reported having to actually educate their provider about their tick-borne disease and use the internet to learn how to manage it as well. And out of the recommendations, 15 emerged around 5 topic areas. And we'll go into those here. So the first one is just in the category of patient-provider interactions. So you saw the listen and believe. Really listen to the tick-borne disease patient. Believe your patients, and really believe that tick-borne diseases exist. There was many comments about just this lack of belief that it existed. Offer compassion and empathy with your patients. Diagnosis and testing was a big one. Ask about hospital tick exposures. Ask your patients about what they do for work, hobbies, and travel. Test early and test for co-infections and discuss patient's symptoms and make a clinical diagnosis. The tests are not reliable, so you have to go beyond that test. So I'm just going to read out the quotes that I presented at in Amsterdam, particularly to this one. So I was never once asked if I was bitten by a tick. Ask questions on one's background, where they live, and daily activities. Ask about outdoor habits and hobbies. Make sure the patient doesn't have an additional tick-borne disease. It should be standard to test for tick-borne diseases, especially in tick-endemic areas. Don't rely solely on lab work for diagnosis. Don't always believe the test results, believe the symptoms. And remember, not everyone will have the bullseye rash. So just to give some support to that. Because of time, I'm not giving you all the quotes, but a few that stuck out, and I think this one's particularly important. Individualized care, approaching each patient individually and realizing that every tick-borne disease patient is differently. That was a huge theme that, for the interviews particularly, that they were able to really kind of go in and emphasize how unique each individual is. Develop individualized care plans in collaboration with your patients. Treat the whole patient. They can have extremely negative effects on overall well-being and quality of life. So no two people are alike and everyone reacts differently. Be supportive of patients' well-being. The emotional mental toll has been massive, and this person wrote, it has affected every part of my life. Management and treatment was the fourth category. So check in and follow up with your patients. This person wrote, this isn't over once you are diagnosed. Continue to follow up and remember in the future that they have had a tick-borne disease. Tick-borne diseases can sort of go in remission. And if you get another bite, it can exacerbate it. So it needs to be considered in the future. Provide evidence-based resources and refers to specialists, and particularly specialists in that tick-borne disease. Remember, there's a lot of them. And the co-infections. Think outside the box. Consider a combination of traditional treatments, alternative therapies, and nutritional changes. So, of course, a lot of nutritional changes with alpha-gal because of mammalian meat consumption and the ingredients that are in other items, but also anti-inflammatory and diets for, there's a lot of inflammation with some of the other tick-borne diseases. And then finally, education. Know the types of tick-borne diseases that are prevalent in the area you practice. So again, these are to the provider. Learn about tick-borne disease and co-infections, and including all of these in the international classification of codes for diseases. And stay current, review the current research. So for this, it was very clear that an earlier diagnosis, individualized care plans, and improving that patient-provider interaction could significantly improve health outcomes and the health status for persons living with a tick-borne disease. I believe that healthcare providers who apply these recommendations in their clinical practice could be more likely to prevent misdiagnosis, mismanagement, or mistreatment. This hasn't been studied, but what I would like to do is that these be included in future healthcare provider education and distributed to healthcare providers globally. It's a global issue. I'm sticking with the time frame here. Okay, last one here, alpha-gal syndrome. Have been increasing. The last two people that I've talked about alpha-gal to told me their spouse was recently diagnosed, Friday and today. So it is out there. It's rapidly emerging tick-borne disease that leads to mammalian meat and product allergies. So this was a separate survey done in 2021. Oh wait, I'm getting to that, sorry. So what also led me to this next study was the response. I had a large, the second highest participants had alpha-gal in this study. And participants were sharing a wide variety of symptoms. And the symptoms didn't fit into the symptoms that I all had. I mean, they did, but they were writing in a lot of other ones that weren't there. They also shared significant mental health, well-being, and adjustment problems related to their diagnosis and management. So this is what sort of led me to this. They shared that providers do not know what alpha-gal is or understand it. People were given medications with gelatin or other things that would cause it. Some people even went into NF6 health-related quality of life survey, and then a perceived symptom rating scale from mild to severe with open-ended questions to describe that rating. And then snowball sampling was similar and used email and mail, but it was over just about a 3-week period that this one was over. And Rebecca McLellan jumped back in and helped with, did all the statistics here. Pearson correlations were conducted to assess the relationship between the factors of well-being and the perceived severity of the alpha-gal symptoms. And a one-way well-to-know was conducted to determine if the food allergy quality of life scale scores were different based on their rating. And then with the descriptions, again, I coded and used similar methods with following it up with qualitative analysis software. Whoa. So there were 430 total participants in this study, 412 adults that were over the age of 18. Most that knew were exposed by a tick, 77%. 10 participants, or 2.4, were actually exposed by a chigger. And then 2% wrote in chigger or tick. They weren't quite sure and had been in both. And in 24 states and 5 countries. So I've got the states that you can see where participants came from here. And age of diagnosis, the majority between 36 and 55. But there was still about a third under 30, 35 or under, and 29%, getting closer up to the third that were over 56. So quite a range on when people are getting diagnosed. This is adults. And then the most participants, almost 40%, have been diagnosed for more than 1 year. 18 parents of children ages 6 to 18 participated, and they were. It wasn't a huge number, so kind of didn't really look at it as much at first and presented on only adults in Amsterdam. And I was getting ready for this presentation. I said, I'm going to look at this a little bit closer. And the range was 6 to 18, been exposed in 8 different states, and 12 out of 18 were by the tick. So again, quite a few here in Virginia, and I just thought it's still valuable. I don't know of any study on children yet with alpha-gal. So to kind of expand a little bit on this. Also in terms of demographics, about half and half, 10 female, 8 male, and those that know, 6 for less than a year, 6 for over a year, and 3 for more than 5 years. So again, I think a pretty good, for 18 participants, you can get a little bit of idea. And here you'll see that similar triggers. So this is what triggers a reaction in these patients. So mammalia meat, this could be, most often the triggers were meat or beef or pork. They wrote in tacos, hot dogs, hamburgers, meatballs, those types of things. Mammalia meat byproducts, so marshmallows, medication, or the gelatin, they wrote in the medication part. But gelatin, milk and other dairy products, carrageenan, which sneaks into a lot of different products, personal care and household products, fumes, so people that are on the have more serious reactions tend to be fume reactive as well. And 1 in 5 adults and 1 in 4 children had to use an EpiPen. And when I asked what, I've written these down, I thought, sorry. So this is what they had to use the EpiPen for, were some of the things I just mentioned: tacos, hot dogs, pulled pork, meatballs, cross-contamination, the medication, natural flavors, wine and alcohol, barbecue fumes, and just fumes from cooking. So those were some that were most often that led them to use an EpiPen. In terms of symptoms, so this is where I got a little bit more into the symptoms that they were all writing in, and also used some work from Scott Collins from North Carolina. So adults, abdominal pain and cramping, followed by itching skin, diarrhea, hives, nausea, lightheadedness, and dizziness. So again, symptoms that mimic a lot of different things, food poisoning that people will say, or just not, it's difficult to make the connection. Also, there could be a very long delay, even 10, 12 hours for a reaction after something you eat. So it's very difficult for patients or doctors to kind of think back to maybe what was the actual trigger. And similar symptoms evidenced by the children exposed. So you can see here, abdominal pain, cramping, diarrhea, nausea. So you think of when a kid might come to you, and they're like, you're having a stomachache all the time. You might need to start considering that child when you have alpha-gal. Not catching it, them having an anaphylactic shock or other reaction can be really scary and life-threatening. Patients or participants were writing in about the extreme anxiety, post-traumatic stress that they were having after having a allergic reaction. So in terms of the statistical analysis results, there was a relationship found between the perceived severity of alpha-gal and their self-reported social functioning, physical functioning, and emotional role functioning. There was also a statistically significant difference shown between the food allergy quality of life total scores, as well as a couple of fears within that I'm going to pull out and show you. And then the qualitative analysis really aligned with the results and showed marked differences as people their rating changed. And so ranging from mild with few to no reactions to severe, highly reactive, and life-threatening. So this is a lot, but I've got it broken down into 3 slides, but I sort of created a continuum, like you see the pain scale or an alpha-gal symptoms, and health-related quality of life continuum. This is the top part of it with the symptoms. So you can have people that may have few to actually no reactions. I had one or two interviews. The participant was like, I don't know if you really want to interview me. And I don't really have any reactions. It's improved my quality of life. I've lost weight. And I'm like, well, that's great. And I absolutely do need to interview you because I need to understand all aspects of this. And that happened on more than one occasion. So very mild symptoms. Most people will not react to dairy when they're at this level. And no one had reported going to the ER. Mild to moderate, people are triggered mostly by ingestion here. And I want to I'll say this probably multiple times, but people will fluctuate along this. Or you might have identifying different levels. So the rarely fume reactive, the symptoms are more annoying versus really severe, and the anaphylaxis is more uncommon here. The ER visits are possible, and the people that also rated a 2, they showed improvement. They had been worse, and they've been able to figure out how to manage it. Because when they don't know how to manage it or know what ingredients to look for, they were higher up. So they showed improvement there. And then I'm going to go over to the extreme on the 5. This is where one person wrote in, they were actually flatlined. Hospitalizations, multiple ER visits, very fume reactive. One person just reacts to all things, everything. So, smells, scents. People wrote in about react to hugging and kissing their spouse if they'd eaten meat, having sexual relations with if they'd had meat. And pets as well. So pets is across the board, but the extreme was quite extreme compared to that. The 4 and the 5 were less differentiated than the other ones, but there was that sort of feeling of death and at number 5 among participants. So when we do the second part and we link it back to the RAND 36 health-related quality of life survey, we found again that it was significant on their rating. So if they rated, it's because this one's back. I'm going the wrong way. I'm almost done, you can see. Okay, here we go. So they go from being able to perform all types of physical activities, no problems with work activities, performing normal social activities, or little no effects on quality of life at 1, to extremely negative effects, frequent interference with normal social activities due to physical and emotional problems, I've circled out the problems with work or other daily activities as a result of physical health, again, kind of linking back to the whole workplace health or prevention programming. And then from the food allergy quality of life scale, these were the elements that came out as statistically significant. So that fear really goes up in terms of having extreme fear of having a reaction, and then also having like the fear of a reaction, and then feeling discouraged during a reaction. So I was just going to read a couple quotes here related to sort of the anxiety and mental health aspects. So this person wrote in, "It's caused severe anxiety and worry every time I eat anything. It's caused severe distrust in the medical field because doctors, nurses, pharmacists, etc. are uneducated and almost accidentally kill me constantly. I feel a burden of family gatherings to the point I don't want to go, and at meals with family I feel left out and alone. In the first few years I felt alone a lot. It caused an eating disorder where I starved myself in fear of eating something wrong and being unhappy with my options and not knowing how to safely eat. I had no medical guidance besides the Facebook group. This one, I was scared for my life at many times. I almost died many times, and I survived anaphylaxis with Benadryl pills for years." My first anaphylactic reaction where I used my EpiPen was just a few days ago, and it caused a major and severe panic attack, and I had to be sedated. So we won't want to discount this is just an allergy to red meat, everyone. It is way more than that, and we need to work with people that are diagnosed. So in conclusion, there is a difference in quality of life based on perceived symptom severity. The findings suggest that as the severity rating increases, emotional, social, and physical functioning decreases. So I think a continuum like this, figuring out how to get it on one page is what I'm working on, may help providers and patients better recognize and understand the complexity and the variability of the allergy and disease and its effects on quality of life. And also providers need to really routinely assess the perceived severity of allergy symptoms and quality of life of their patients. And then, again, provide evidence-based resources to help them with this life-changing diagnosis. So what is next? I gave you a lot there. I appreciate you all for hanging in there through this. Surveillance is continuing. I have a student doing it in Buckingham County. She's finishing up. She's been doing the summer and fall with public recreation areas and parks again. But the Danielle Rapp from the Claytor Nature Center has started the ERIN, it's the Ecological Research as Education Network, and worked with a professor in Roanoke to create protocols to look at urban versus rural surveillance, and has involved biology and environmental sciences, and they're working on that in their labs. So I'm going to be excited to get that urban data, but I'm sort of taking a step back from the surveillance a little bit and really trying to get into the education prevention and expand on what I'm doing here. So at first I'm doing a presentation on Friday at Claytor, and I'm going to do a little bit more about patient experiences and prevention, how to prevent, how to take it off correctly, take it off. And these are the participants in the tick-borne disease experience study just from Virginia. So I was able to get, so I'm going to go in, there was 101 adults and 13 parents for that. So I'm going to get into the little bit more in the details of Virginia. Specifically on Friday, I mentioned this symposium. I'm doing a presentation on rationale and resources for implementing workplace tick-borne disease prevention programs. I'm working on all of these to get these into publications. These are the journals that I've identified. And I'm working on some toolkits for employers so that they can easily implement a program and sort of a packet, and also for new providers in Virginia. I kind of have new italicized because I think it should be all providers. I've been in contact with Dean Jeremy Welsh about doing these sort of packets and getting them out there, and possible some CME opportunities for providers. And then I'm going to do a study with health and physical education teachers with Heather Ryan Sigler and Katie Bowman. Schools were also identified as a priority area, so getting in some curriculum and getting these kids in the area to know. And then my class, we're doing some student research to practice projects that they'll actually implement some prevention programs in the spring. And we're doing that with, they've each got a different population. We've got the one student with the child caregivers and parents in Buckingham County, doing endurance athletes, disc golfers, agricultural workers, area administrators, parents, and students at Fire. So those are my references. I want to thank everybody that's been involved to date. This is sort of who's been involved to date, mention who's going forward. Rebecca and Judy and Jamie, I'd say, have really been key people in different aspects of this. Kim Geyer helped with a lot of my getting all my stuff. Thank you, Dave, for all getting us maps into it. I've been inspired. I audited his map, his intro to geospatial tools class. That was awesome. Jennifer Stiersky brought in Westover honors. Lori Henry Stone starting to kind of integrate it along with Daniel Rack. So thank you, everyone, again for coming. I got 12:46, so I left a few minutes for questions. And I know I threw a lot at you. So thank you for coming. Any questions or comments?
I commend you for getting everyone involved.
Thank you.
So you mentioned the State Department of Health. What's been the role of reaction at the federal level with the CDC and all this?
Of this?
Just to take
Well,
you don't seem to hear that. Obviously COVID stuff makes the news more, but what's their role?
so they actually just, this year got pages up on AlphaGal. It's not reportable to them. The Tick-borne Disease Working Group is working to make recommendations to Congress at the federal level. But CDC is primarily informative and kind of putting together the information. I'd say it's definitely improved over the years that I've been working on it, but there's still some controversies, particularly around Lyme, but they are getting better in terms of surveillance and what they're counting as surveillance. Does that help? Okay. If not, I can try to. Yeah.
I have a question. So you mentioned on your continuum for AlphaGal that over time some people were better able to manage their experience and improve their quality of life. And I know that among people who came to me, they'll anecdotally say you get better with time. Did you notice any sort of association between time since they were diagnosed and where they fell on that continuum? Or did you find people who had had it for a long time were still in the red?
So some, yes, but I didn't look at that association of how long. That would be something to look at the data more at to see with their length of time since diagnosis and some of their qualitative responses, because the qualitative responses and interviews is where I got a lot more about the improvement over time, going into remission, learning about the numbers that don't mean a whole lot. Because people will see a number and they think, oh, my number will really work to get that number down, but the number doesn't necessarily correlate with the symptoms and how bad they are. I've also been sort of, hanging out on all of the support group Facebook pages, and there's a really active AlphaGal one, and so some of their experiences, I'd say, would align with this, but you've got, that would be interesting to pull out and look and see if there's a correlation there.
Dr. Hall, thank you for a great presentation. 2 questions, just for clarity. Is everyone susceptible for TBDs across the board, age? Is there a
if you just sit
specific...
inside and don't go outside,
All right.
but yes.
The Xbox player is probably off the list.
So actually, children are really susceptible because they're playing outside and things, and so you'll see in terms of age and prevalence numbers. I was just looking at it again this morning from the CDC, so they do some of that higher, that type of information. But and 0 to 9 are the highest. So working outdoors, recreating outdoors in wooded areas, going off trails, there's things that you can put yourself in at more risk. But otherwise, everybody that goes outside and plays outside in a tick endemic area is susceptible. Not every tick has a tick-borne disease. So not every bite that you get means that you're gonna have a tick-borne disease, but if you get bit, then you need to kind of monitor your symptoms. Right now, there is no known attachment time for alpha-gal syndrome, which is scary. That's the Lone Star tick. So, you know, there's research that it takes 20 hours or something for Lyme disease. I don't agree with that. So you just need to get that tick off right away.
And just a second question, your continuum was awesome. I mean, that is highly usable, right? I love that. Are there any patient populations that would predict someone would be red versus yellow on your continuum?
So my thought was it's called SAT treatment or SAAT. And they have a place in Forest. It's a type of acupuncture, and they put a thing behind your ear for 3 weeks. And people have had really good success with that. So a thought was to maybe see if I could work with them and do a before and after to validate the continuum a little bit more, and see if I could do sort of before treatment, after treatment. But I am exploring on how to best validate the continuum to get it more out there.
Jenny, did you, in your survey, notice a correlation between long tick-borne disease and immunosuppressed conditions like,
So people with chronic Lyme, post-treatment Lyme disease, more people with Lyme will have multiple co-infections, and the research will say that as well. And with the chronic Lyme, because of years of misdiagnosis, many end up with multiple conditions. Whether one started the other, you know, did the Lyme come first, or the multiple sclerosis, or fibromyalgia, or, you know, there could be multiple conditions going on, and what came first sometimes isn't unknown. But it's not uncommon for people to have multiple things going on. Yes.
At one point you mentioned some tick management protocols.
Oh,
And
yeah.
you said there are some extreme ones that you don't recommend. Could you say something about what tick management means?
Yeah, I don't remember what I said that was extreme don't do, did I?
No, you just mentioned it, you mean like, because it's impossible for us to get rid of the world of ticks.
Oh,
So, you know,
yeah, so I, like, the eliminate of the hierarchy, because I said it was like impossible or near impossible to get rid of. So, I was just in Amsterdam, it would have been lovely for the science department to be there, because it was a lot of science, on mice and animals. But they're looking at different ways of like treating corn pellets and feeding the deer. So they did this big study, and it was the deer. It was working to prevent the tick bites and actually the tick even on the deer and sort of killing them off. A newer one that I've seen that is not extreme is balsam fir. That's showing some promise with that, which would be nice for like more of a natural way to prevent tick-borne diseases. I'm trying to think. Others are just, you know, a lot of chemical spraying that is maybe unrealistic for communities or areas. Although in Buckingham County, my student has been asking and trying to find out some places they do treat, like some of the main recreation areas, and it's correlated with less ticks that she's finding. Then other just changes in landscaping and the ecological, you know, but with us building and, you know, losing animals starting to here, I can't believe how many deer are here everywhere in the community and in the city, even here on campus. And the one problem with the pellets is that it took them a long time to get this point, is then you can't, there's a wait period before a person can consume the meat. So, and I think they were from Connecticut, I want to say, and they have a law, like if you hit a deer with a car, you can still consume it. So that also messes with can you really, is that going to work? How is it? Anything else?
I'll just say, I lived in Loudoun County in Northern Virginia for several years, and to Mike's question, Loudoun County Parks and Rec sprayed balsam fir and cedar on all their public walk spaces. So I don't know if that worked or not, but for what it's worth, that county had been using that when I was up there. They had signs very similar to yours, but this area has ticks. We're using this naturopathic approach. I'm assuming that's natural, right, balsam fir? It's not MSG. So anyways, just put it out there. I do know that's a very large county, a lot of parks. They were using balsam fir and cedar spray. Whether it works.
And the integrated, I did a webinar, Stafford, I think is his name, he's sort of the guru in the US on this integrated tick management and different methods, but it really takes a lot of, you can't do one thing alone.
All right, thank you, Dr. Hall.
Thank you so much, everyone. I really appreciate it. If you have
Thank
any
you,
follow-up questions or ideas or want to collaborate, you can see I really like to work with other people, so. Thank you, have a good one.
Thank you, everyone.